Praise to Lord Manjunath Swami, my Honorable Chancellors, Pujya Shri Dr. Virendra Hegdeji, Honorable Vice Chancellor Dr. Niranjan Kumar, Executive Director and Member Board of Governance Srimati Padmalata Niranjan Kumar, Director Administration Sri Saket Shetty, Pro Vice Chancellors Dr. S.K. Joshi, Sri Jivendra Kumar, Registrar Dr. Colonel U.S. Dinesh, Deputy Registrar Dr. Ajanta G.S. and Principal Dr. Sunil K.M. Before I start, I would like to take you to the journey of my campus where I work. We have a beautiful campus. Which includes SDM Medical College. We have big hospitals which include specialties and super specialties. We have big libraries which is medical, physiotherapy, nursing, with different varieties of books and journals which are recent. This is the Department of Physiotherapy. We work in the different areas, pediatric, OPD based interventions, treadmill based interventions. We conduct a lot of workshops, hand injuries, and we do conduct a lot of camps at the community level. That's where I work, that's SDM College of Physiotherapy. Now, we are at 12,704 kilometers. A couple of years or couple of decades back, if somebody would have told me that we will be able to see each other or talk with each other, they would have definitely told, are you kidding me? Yeah, that would have been a question. But now we know that we can talk at 12,000 kilometers also and we can see each other. Similarly, therapists have thought that rehab exercises for children with cerebral palsy is fun, is a question mark. And when I say that it's fun, they think that I am kidding. So what I will say is that you laugh because you think I am kidding, and I too laugh because I think I am not kidding. And my consecutive slides will prove whether the rehab exercises are fun for children or not fun for the children. So these are my authors. Dr. Tony, myself, Anuprita, Kavisha, and my co-authors, my postgraduate students from 2014 to 2019 batch. This brief about me. I completed my undergraduation from Manipal University, then my post-graduation from Rajiv Gandhi University in SDM College of Physiotherapy and postdoctorate from University of Manitoba. I have few awards on my name. And couple of courses I completed in NDT, sensory integrations, aquatic, craniosacral therapy, yoga therapy, and couple of memberships on my name. If you ask me my routine, I am a teacher which teaches to the undergraduate as well as to the postgraduate students. And I basically teach them exercise therapy, that's kinesiology, and physiotherapy in neurology and physiotherapy in pediatrics. I do have certain responsibilities along with this is I am intern coordinator NABH, I am member for the PhD committee, academic council and subject expert. As a clinician, if you look at the census, we see nearly 5,000 patients in a year, which includes the children with neuro-developmental disorders in majority and also the children with cardiorespiratory dysfunctions, musculoskeletal dysfunctions. So we start working in an ICU. We have a fantastic pediatric medical unit which is headed by Dr. Vijay Kulkarni. And in an ICU, we see nearly 6 to 8 cases, and our major interventions are early intervention. We do have a PICU where we mainly look after the cardiorespiratory dysfunctions and try to stabilize these patients early, and we start the developmental care in the initial stage itself. We do have a very good pediatric ward where the patients are entered with acute illness, and we take care of basically the chest care and the developmental care. We have a pediatric physiotherapy OPD, which is managed by myself and my colleague Dr. Jyoti Jivannavar. We see in a day 30 to 40 patients, and our major interventions includes neuro-developmental techniques, sensory integrations, and computer game rehabilitations. Type of patients we see are neuro-developmental disorders, musculoskeletal, and majority of them with the syndromes. This is about my OPD, what we do in the OPD. So we give them a vestibular ball-based exercise interventions, trampoline-based interventions, computer game-based rehabilitations. We do go to the government orphan school and we treat the children with neurodevelopmental disorder there. We go to the one of those exceptional children's school, that is Usha School for Exceptional Children. We have there nearly 100 children in that particular school, and majority of them are having neurodevelopmental disorders and having a mental retardation as one of the component. Along with the therapies what we incorporate into the pediatric OPD in SDM, we do have there associated with hydrotherapy and hippotherapy, music therapy. It's basically a multidisciplinary school which involves all these therapies there. We do get a lot of references from the in and around the consultant who work in 60 to 100 kilometer areas, and we give them the protocol for the interventions, and they follow up with us in a monthly basis depending upon the distance, the cases which can come to us and take the next protocol. Since the today's presentation is focusing towards the neurodevelopmental disorder, and the majority of the neurodevelopmental disorder is a cerebral palsy, so as we know that now there is a little increase into the prevalence, that is 2 to 4 per 1,000 live births. And if you take in a scenario in India, there are 12 million children which are suffering from neurodevelopmental disorders, of which 10% are from the hilly areas, 13% are from the urban areas, and 18% are from the rural areas. With this, I shift towards the next presentation, that is the research studies. I have 32 publications done. A few of them which I'll be touch upon today. So, couple of studies we done in the NICUs. So, if you look at this particular study, we studied basically the length of gastrocnemius and soleus muscle tendon in 120 infants. And what it shows is that there is a muscle tendon unit length there is a significant difference between the preterm as well as the postterm children's. We did study on a single case studies in the beginning when we wanted to assess the applicability of the PDMS2. So first study we conducted was on choreotheatoid cerebral palsy, and next study we conducted was on spastic diplegia. We said that the PDMS2 is applicable in children with disability and it can be used as one of the evaluation tool. So these are the few graphs that it shows that the question is showing poor or below average. That means the children, when you evaluate on PDMS2, will give a low score. So we did a longer study that is including 100 children and quantifying whether the PDMS2 can quantify the gross motor developmental delay or not, and it actually quantifies the gross motor developmental delay on our result it shows. Then we did a couple of studies in a normal school where we studied the hypermobility between boys and girls, and we tried to find out what is the correlation for this hypermobility. Some contrasting results for us. We had 5 to 15% documented in the literature, whereas we got nearly 33.73% to 34.29% of children having hypermobility. When we tried to find out what is the reason for it, what is the correlation for it, we found that it was more prevalent underweight children. So probably the underweight was one of the cause which we found for that. We did a study in the children with mental retardation, and we found in a 205 population, that was the sample size, we found that 78.46% children were actually underweight and not overweight and obese. Though there is a notion that children with mental retardation will be obese because of physical immobility. But here we got little contrasting results here too. Another study we did it on nocturnal neurasis. First we developed the reliable and valid questionnaire between 6 to 15 years of children. And later we studied the prevalence of nocturnal neurasis in 16 to 15 years. What was surprising for us was the prevalence was 12.67% between 6 to 15 years, but as the age increased, the prevalence actually reduced. And when we asked about whether the parents are aware and do they consider this as a major issue, the parents' awareness among them was hardly nearly 36%. So what we concluded from that even the nocturnal neurasis has to be considered as an early intervention and not only the NDDs to be considered. There are a couple of studies which are in progression for the publication. One of the study which we done on taping, there is a lot of talk about the taping. So we did this study on taping where we took the children with neurodevelopmental disorder who had a pronated feet. What we found is that it was a crossover trial. What we found was there was no difference between A and B group, but if you take it in a whole group, that is taping as well as exercise, it did show some changes in the intervention. So probably we can say that taping can be used as an adjunct in the therapy. So, if you look at all these things, we were doing a lot of neurodevelopmental based techniques, we were doing a lot of hippotherapy, we were doing a lot of hydrotherapy, but somewhere the major questions were coming was that it was difficult to engage the children with neurodevelopmental disorder. And a lot of therapists were saying that somewhere we get stuck with the child when we are treating them. That the hand function is not completely improved or the leg function is not completely improved. And very important was we were not able to keep their motivation. So that was the need for us to going for an innovation, and definitely we needed something which is very cost effective. So that's where the collaboration came into the picture with University of Manitoba and SDM University. Now you might ask me a question, why did you select computer game rehabilitation? The man behind this particular approach and the development is Dr. Tony. So if you look at the upper extremity treatment at present, what we are having is, we have a lot of treatment which is showing to be effective. For example, constant induced movement therapy, bimanual intensive task therapy, and lots of therapies which are task repetitive therapies. And most of the commonest, if you look into your routine practice, is that what you do is a hand weight bearing. Now when you do a hand weight bearing, let us keep one thing in the mind, that the hand is for a purpose of manipulation and not for weight bearing, whereas the leg is for the purpose of weight bearing and locomotion and not for the purpose of manipulation. So we were missing somewhere a lot of manipulation, and that's what CGR gives about. And similarly, when we walk, we do not only walk, we do a dual tasking there. So gait has a dual tasking component as well as the hand manipulation has a dual tasking component. That's what the CGR was giving, and that's what influenced us to go ahead with this particular project. So you might ask me how it all started. It was just in a formal discussion with one of our ex-student, Dr. Anuprita, who came to us and just discussed the idea about this one, and then we thought, yes, this is something different and we should try out for. And we went through this, that we had a lots of Skype meetings, we had a lots of WhatsApp calls, and we finalized the protocol. We took the ethical approvals, and with all those things, we continued the data collection and then the statistical analysis and result. All this contained 1,000+ emails and 100+ Skype calls, and we prepared finally manuscripts. We have 3 manuscripts published already into the index journal and 5 are into the preparation. So this internal collaboration, which was between the University of Manitoba and University of Sri Dharmasthala, we had a basic goal was to produce innovative and cost-effective therapeutic approach to improve the outcomes for children with cerebral palsy and other neurodevelopmental disorders. This included 12-week research exchange with Anuprita Kanetkar and 8-week research exchange with Kavisha Mehta. Now what this Tele-Rehab protocol was all about, or rehabilitation protocol was all about. Now rehabilitation, I say, that is when I am using it in my therapy, and tele-rehabilitation when I say when I am using it in the patient, where they can go to the home and do. So this particular thing has basically 2 components, that's physical exercise space and digital game space, or you can say that as a cognitive space. Now what happens in this is, you can have an object, whichever object you want or whichever object you use in your daily routines, and you can decide the games which are available commercially, choose them because they are the one which is going to enter into the cognitive space, or through which you are going to enter into the cognitive space, whereas this one is in a physical space. So these are the few examples of different objects what you can use. Now if you compare with the routine therapy, we do not use lot many objects. Probably we play with the children with 1 or 2 objects, but here we can use the objects which are required for their daily activities. 1, 2, we can use the object depending upon what is the starting point for emerging skill, and it is easy to eliminate the gravity, and definitely very important, it reduces the need for robotic assisted devices. Let me point out here one thing is that no more a passive therapy is useful. Unless and until the therapy is active, you cannot get the results. And so this induces that activeness, that cognitive space to be included with a motor space. So these are the again few examples of the objects which you can use, and you can apply a mouse to that and you can manipulate the object. That's what, there are few examples of the same. This is what is showing an application of the mouse on various objects. So you can use any object which you want to be using, and depending upon what function or what task you wanted to look for. So this, once you apply the object, how we can use this as an assessment software. What it does, it provides an objective outcome measure to track change, detect problems and guide progression, and provides timely feedback for child, parent and therapist, and helps in telemonitoring. That's very important. And you can have a long-term goals to collect longitudinal electronic records to establish database and registry. So basically it's going to help us to have a data which is electronically recorded and which can be saved electronically. So there is an assessment module. In the assessment module, what you do is you try to fix the mouse onto the object and then play with the game, and then you will see certain objects coming up. Your goal is to catch that object and not the distractor, and then you produce a beautiful graph which is measured on the basis of success rate, response time, movement accuracy and movement variation. So here is an that's how it looks like an assorted graph. That is completely, this is how it will look like. The graph is once you do the evaluation. So here is an example of how you do without distractors. So this is basically showing the settings of the game. So it gives you the flexibility to select what kind of setting you want to do, and that will decide what kind of precise movement you want to do. And then you give the name to the file, and then you play with the object. Now here there is no distractor. The job is that you are supposed to catch the ball. So the patient will be moving the hand with considering this is an object, that's a ball, and then once it's played to game, and then you get a graph which is measured based upon how it was, that is movement accuracy, what was the response time, what was the onset of time. That's all details of that it will be giving. And then you can have without distractors, and you can have with distractors. So again here showing the same is you have on the settings. Once you fix up with the settings, that is again what sensitivity you are keeping, what is an amplitude you want in the movement, how precise you want the movement, how large you want the movement, where exactly you want the movement, whether you want the movement happening at the wrist, whether you want the movement happening at the shoulder, or whether you want the movement to be happening at the elbow. So similar object, now if you see there is a distractor, okay, or the object which is coming is in a different way. And once the game is over, you can see the graph. So you can see the previous graph versus this. So this was little haphazard as compared to the previous one because there was a distractor there. Similarly, you can have multiple distractors coming in. So likewise, you can assess the different ways, and then you have a tracking mode. In the tracking mode, what you do is you try to use again similar way, go for a setting, file name, and now what you do in this is you try to fix the mouse on your head, and then you are playing with that. So here is the object which is you are supposed to be going along with the objects. So here do a lot of using visual-vestibular activities, that is head turning, and along with that you are working on the visual movements also. So that's about the visual tracking. Now what we discussed is how do we assess. Now when we treat, we use these different commercial games which are available on bigfish.com, and you can use these games having what therapeutic value you want. It is not that you just pick up any game and you can just start playing with that. It all depends upon what game you want and what is the function you want. So that's why this picture is that you should be knowing what cognitive function you are looking for, what movement you are looking for. Depending upon that, you select the game. So here is one of the example of aqua ball where you play. That's one of the very simplest or the beginning game what we use in the rehabilitation. Now, this is in a background what I gave. Depending upon this background, we conducted a study. The first study was to establish the reliability and validity of a computer game-based assessment tool for object manipulation skill in children with cerebral palsy, that is NDD. And second study we did was exploratory RCT, and we took 35 children in our reliability validity study, whereas 60 children in our exploratory RCT. So in our RCT study, we studied the test-retest reliability and convergent validity. Now this was our inclusion and exclusion criteria, where we had GMFCS level 2 to 4 and max level 2 to 4. We did evaluate the children on mini-mental assessment scale, and we make it sure that the children which were included are not having any cognitive deficits. They were the children who were having a mild cognitive deficit. So we excluded the other children who had the impairments of auditory visual systems or fixed deformities. So we had 35 children in them, and max level average was 2. So if you look at the objects which we used, a few of the objects which I showed, we used 4 objects for that. That is peanut ball, then soccer ball, then cone, and thick plastic ring, and tennis ball. These are the objects which we used, and we did these movements analysis for the test-retest reliability, and it was a fantastic results what we got. And we showed that in the convergent validity about the quest, you can see here with dissociated movement, 19 of 20 possible comparisons were not significant, and with grasp, 16 of 20 possible comparisons were not significant. Now you would say that it does not have a validity of a convergent validity. What I would suggest, what I would say here is that the convergent validity is not there because what Quest assesses on the 5 of its component, the neurofunctional software evaluation does not assess that. Because Quest assesses basically the dissociated movements or grasp, whereas this particular our tool assesses about the reaction time, how precise the movement was, how did the movement took the onset, and how movement variation was, which none of these assessment tools uses that. That's where the convergent validity did not have any significance with that in our study. Similar results we found with the PDMS2 too also. Why? Because in PDMS2 we have a couple of objects which we use. Maybe it's a cube or sometimes a pen and a paper. That's what you use. So the fine motor what you are using for a manipulation task is very limited items, whereas in the NFE software there are larger number of items. That's why 19 out of 20 possible comparisons were not significant. Similar thing has happened with the visuomotor scores also. So what I would like to conclude here is that though we had majority of the reliability was between 0.6 to 0.8 and high minimal detectable change values which were ranged between 30 to 60. That was the group means. A single case study was also produced on the similar background, that is a computer game assisted repetitive task practice based upper extremity on a single case study in a hemiparetic child. And we did get a good results in that baseline scores were 41 which went up to 49 and which were 87 which went up to 105, and you can see that nearly 69.4 to 92%, that is 47.26% improvement we found in the children. You can see here something interesting, that you can see the scores which are 100 here, 100 here. Now what does it mean is that the child has already reached the optimal level on these components. So if someone says me that looking at this graph, we'll say that okay, child has a good function in the upper extremity. But when I look at the graphs, it doesn't say that. My pre-intervention to post-intervention, there is definitely improvement, but my graphs are not as smooth as they are into the normal children. So it is able to pick up that small dysfunction which is still present in the hand, and this child has a problem at the finger manipulations, and that is why his graphs are improved, no doubt about it, and you saw a lot of improvement onto the Quest and PDMS2, but here the graphs are still getting clearer and clearer. So what it says is that though your scores are higher on to the qualitative assessment what you did it on PDMS and Quest, you might not have a clean graph on NFE. That means that it is sensitive enough to pick up even a small dysfunction which is remaining. From there we moved on to our RCT study. A protocol of the RCT study was published in a JMI International Journal. Our RCT study consists of 45 minutes of therapy for 3 days per week for 16 weeks. We had a primary outcomes as a PDMS to Quest and secondary outcomes as our NFU or computerized hand arm assessment tool, which I am talking about. We had children, all children who had NDD. We included again GMFCS max level, and we took the help of our psychologist who helped us with evaluating on Vinland social maturity scale, which excluded the children from cognitive deficiencies which are moderate to severe in level. So there was a multidisciplinary team working for that. And then our treatment protocol include the integration of principles of CIMT, habit, play therapy, repeated practice measures. Now you would say that here CIMT is not really forced. See, the child is using one hand. That's what basically the CIMT wants to tell me, that constraint-induced movement therapy means I am constraining in a good hand and asking an impaired hand to be working. But what was happening in a routine therapy was that whenever I was constraining in a good hand, the child was actually getting frustrated. Similarly, the parents were also getting frustrated with this. That's what was the one which we could eliminate from this one. So these are the certain our treatment protocols, and we use rehabilitation games. This is just to show you our treatment session protocol. We did a consent form, and then we had an individual assessment forms which were filled like this on a daily routine basis, and then each file was prepared for every child and kept it. Now just to show you what are the certain objects which use here, only I am showing you the 7 objects which I have used. Now if you see at this object, a bolster, this is basically when we wanted to look towards the child, that I wanted basically an elbow extension and getting a shoulder stabilizer. That's where I am using a larger object rather than using a smaller object. But as the child develops the more and more control over proximal, I go more distal. So in this child, there isn't a good proximal control, so I am using basically a distal one, where the child is manipulating a cone with the supination pronation with using the hand. Here I am going for a bimanual task, where I am using a peanut ball. Here I am using a ring. Again, as I said, it depends upon the control how much I have got it. Simulation device, which is basically working onto the fingers. And again on a small ball for bimanual function. And when I get a good amount of control and when I wanted to use fingers, I can use one of the object of the pegboard what we use in routine. So if you look at the pre and post graphs, you can see them. The pre-graph, see the pre-graph how it was very haphazard, I would say, or by only seeing you can say that no, this graph doesn't look really good, whereas this graph really looks good. So that's become so objectively to be quantified on this basis that pre to post there is a change. Okay. Similarly, we did the evaluation on our quantitative study, that is success rate, movement error, and average movement onset time. What we got the results is that we got an experimental group showed a larger improvement in success rate as well as on the average movement onset time. So basically the control group had a little lesser improvement as compared to the group which was experimental, that is computer-based game rehabilitation. Similarly, we saw the results in Quest and PDMS too, though both the groups showed the significant improvement, but there was larger change into the group which was experimental in nature. So that's what were the findings of our quantitative study. We did take the interview of our parents who were involved in these studies, and we asked them what did they find or what was their opinion about this. What they said was that they just like the design of CRP. Every game task is designed to help the hand balance and improve the hand strength and eye coordination. See, there's a lot of demand, lot of thought that the hand and eye coordination is required for the objects. Whereas in our routine therapy, we do not pay so much of attention to this one. Whereas these parents said that it was a positive, that they find that their child is becoming stronger now. But one of the parents said that this child was hate the computer, but then she was confining that after a couple of months or in a month he will be able to respond, and this child really responded later on. So what we would like to say that it is not an easy for a child to immediately accommodate for the therapy. It might take 2 or 3 sessions to go for it. Very important was therapist response, because I said that, am I kidding today? So you might say that the therapists are thinking that I am kidding, but here is the response of the therapist. So when we asked them, when you compare to the usual therapy exercise, how easy or difficult was it to implement the game exercise program? So how did they find whether it was difficult as compared to conventional? So they said that it makes it boring, the previous one, and it was difficult to be keeping the therapist's attention to these kids. That's what they were finding. But with this, the game-based exercise make it fun-loving for children and increase their attention span. So that's what we were talking about, that motivation and engagement is the very important component to keep going the therapy for a longer hours and a longer period. So that's what was happening here. Second, it said that at usual program, the game exercise program was easy for them to implement, and it made it easier for the therapist to get the child involved in the therapy. That's another important thing, that you need an involvement of the therapist, involvement of the child. Initially, though, it became uncomfortable for them to start it, but then, however, after taking few sessions, it becomes convenient and easy to use. So this is what was the response on question 2. And question 3, when we asked what qualities did the computer game-based intervention possess, if any, that made engaging and fun for the children than the conventional protocol. What they said, that basically the colorful and engagement of the children, it was very playful to the children, and it was problem solving. That's very important. And they said that it's a fun for the child. So if you remember my title, I said that exercise rehab is a fun for the children. So that's what even the therapist has to say here, that yes, it's a fun for the children. When we asked about the recommendation for intervention of technology in your peers and colleagues, most of them said yes for it, and they said the reason that it's easy for implementation, it's clinic as well as at home, because we are looking towards that the therapy should be a continuous program and it should be carried out at home. So therapist feels that it can be carried out at the home. Then they said the reason that working on a hand function as it is, very difficult to work on each fine motor skill. That's what I was trying to tell, that we as a therapist, we come till the shoulder, we get till the elbow, but we do really get tired at the time when we reach towards the fingers. And this is what the therapist has to say, that each fine motor skill was difficult beginning when they were doing a conventional part, but when they were using on a computer game rehab, it was easy for them to be using a fine motor skills. So this emphasized a lot upon a fine motor skills for the children. So when we asked, they said that it is basically the engaging and involving in an activity which was playful. So we asked about some amount of advice to them. Most of them had no advice apart from small advices related to how to use the software. Second research exchange we had with Kavisha Mehta about the psychometric properties of game-based intervention in balance in 30 children with cerebral palsy, that is neuro-developmental disorders, and 30 age-matched children. And we are doing test-retest reliability. This study is undergoing convergent validity and non-group validities. And second study is about exploratory RCT to examine the feasibility, acceptance, and estimation of effectiveness of an innovative game-assisted exercise program. We are taking children here up to 12 years of age. Now what is this all content about? This is an ongoing project with the collaboration. We have been taking 40 children with cerebral palsy, and the participants will be assigned with randomly in the experimental as well as in the control group, and it's a 12-week intervention program. It includes the platform which consists of miniature inertial mouse which you saw previously, laptop, PC or tablet, variety of compliant surfaces for balance training, like these surfaces which we call it as like an air bladder. You can use this surface or you can use the foam for that purpose. These are the various surfaces which can be used, where we make the children to stand on that and then take their balance assessment. And definitely pool of games for therapeutic purpose, and we use FSS software for the pressure mapping. Now what is FSS software does? The FSS software is used for recording the balance capability of an individual during various activities. The participant needs to stand on this pressure mat, and therapist starts recording the foot pressures. So these are the foot pressures what the therapist is recording. And the visual analysis of the file will give us a fair idea about the various pressure and weight bearing areas of the foot. So this color one will give us the ideas about where are the pressures being exerted. And then this particular file gets evaluated. Our assessment protocol includes basically the standing with eyes open, then standing with eyes closed, then standing and playing visual motor tracking game, then playing an easy cognitive game, and then playing a difficult cognitive game. So if you look at this particular protocol, you might think of a CTSIB, that is clinical test for sensory interaction battery. That's a part of it what we are using as on our protocol. So, how does, is there a relationship between standing balance and visual tracking? So here is an example which is explained that. So when you're standing on a normal surface, you see the balance performance. The excursion is very less. When you see the visual tracking, it's almost okay or normal. Or you can say good tracking. But when you're standing on a sponge, you see the excursion is huge on all the directions. Eyes closed, so you cannot perform a visual tracking. And when you stand on a foam, you see the excursion is again larger, but you see the tracking is fair there. So what does it say is that whenever you challenge the surface, your visual tracking is challenged. Similarly, your balance is challenged. So similar way, looking at the relationship between the cognitive game when you play with them. So when you play a cognitive game along with a surface which you have changed, you would see something like this. So when target only on a fixed surface, you see the excursion is smaller. When you see a target plus distractor on a fixed surface, you see the excursion is larger than this one. But when you see a target with distractor and sponge on it, you see there is a huge amount of distraction or the huge amount of excursion which is happening in all the directions. So which again proves that a cognitive added to the balance has a lot of influence on balance. That's why dual task plays an important role when you want to improve the balance in children with cerebral palsy. So we are conducting the similar study, that is effectiveness of computer-aided rehabilitation versus conventional physiotherapy treatment for balance in children with neuro-developmental disorder, an exploratory randomized controlled trial. This is an ongoing trial. This is how our protocol is documented. And what we do in this is we try to make the child with keeping a mouse on the head, and then the child plays the game. And here if you see, here is a surface which is changed. It's on a tilt board on which the child is standing. So the surface challenge plus cognitive challenge. So the child is doing a dual tasking here and interacting with that computer game. So while doing so, it's challenging the balance, and that's what is an hypothesis that it improves the balance. So if you look at the initial reports or initial results on PDMS2, we did almost nearly finished 5 or 6 of them, and 10 of them are ongoing. You can see the gain is into the experimental group is that S is for stationary component of the PDMS2 and L is for locomotion component of PDMS2. You can see that gain is 6, 4 up to 14, and only in one children there is no much gain has occurred. But otherwise, if you see all the children, there is a large gain which has occurred, which has gone up to 16 in locomotion and 14 in stationary. So stationary is where the body is stable, and locomotion where the body is in movement. So what it says is that dual task will improve your gait also, that is your locomotion also. When you look at these PDMS2 scores into the control group, look at the gain. Almost there is no much gain into the conventional group, though there is one of the client improved almost up to 12. Otherwise, all the children you can see, there is no much gain has occurred post-intervention. We did take a pediatric Burr balance scale, and you can see the gain in the control group as well as in the experimental group. Experimental group you can see a minimum up to 4, which has gone up to 12. Whereas into the control group, it's no gain or maximum is 4 gain. So the primary result shows that dual tasking or having this particular cognitive based rehabilitation, including into the game based rehabilitation, improves the balance of the children. And this is how the pressure mat data looks like. That the result clearly states that there are improvements in the total path length values from pre to post 8 weeks in both the groups, and especially more into the experimental group. And when compared pre to post 8-week result, concluded that post results were better. So we are into the continuation of this particular study and not yet completed. Let's hear to the parents what they wanted to say about this particular thing.
I'm Alize Rukri's mother. We have been coming here for her physiotherapy sessions since Feb 2019. We came here because she had developmental delays due to which she could not sit without support, crawl, and also she was not able to do much things which babies normally do. So once her physiotherapy session started, she started gaining her strength, due to which she started sitting without support, and she is now able to crawl. She speaks very clearly also, and she walks without without support for few steps, and with minimal support she walks very nicely. Along with this, using the computer-based rehabilitation, her balance has improved, and she is weight bearing on her legs very nicely. This all has happened because of very good support from all the doctors under the guidance of Dr. Sanjay, who keeps an eye on her and monitors time to time.
So that's what the parent has to say. We have a couple of another studies developed, that is development of hand function rehabilitation platform for children with cerebral palsy, acquired brain injuries. We took 50 children with CP and 50 healthy children to form the normatives, and we used cone, ring, tennis ball and fork as an object manipulation. So that's how it looks like when we did a tracking mode. Now you see here a healthy child is having a good tracking, whereas the child with hemiplegia has a distorted tracking here. So what is this tells about that? See, these are the different objects, and this is about the tracking or what we use. Now what does it say? That most of the time, though the child is having visual issues because of which he has a poor postural control, which is getting usually ignored. But this graph clearly says that the children with hemiplegia, for example, has issues with the tracking, that means visual issues. So this can be sorted out when you use these computer-based game rehabilitation protocols, because you need to have a visual as well as the motor, that is eye-hand coordinations for that. And you can see how does the healthy child performance was versus the child with cerebral palsy. You can see the graph which is very neat and clean versus a graph which is very distorted in children with cerebral palsy. And when we did the comparison with the normal children, we got on surprising results. That was the significant difference in all 4 outcome measures in the control group and children with max 1 level. Means what does it say is that you say that the max level 1 is almost to the normal. But in our case, max level 1 also showed the difference as compared to the normal children. Though there was a difference between cerebral palsy and the normal children at all the levels, that is success rate and movement error, but surprisingly, max level 1 also had the difference between the normal as well as the max level 1. So that says that this tool is particularly maybe able to take out a very sensitive or very deficient and very remaining part of the component of the dysfunction also, which the max on grossly when we evaluate and say max 1 may not be able to pick it up that. So you might say that I might have to revise about it, but yes, then that's what was our finding of these normal children and the children with cerebral palsies. Now we are doing one of the pilot study on tele-rehabilitation. As you saw, the therapist also said that it should be a carryover towards the home. So we have been recruited now, total 6 children here, of which 3 we have completed and 3 are recruited in Canada, Winnipeg. So this is what is our tele-rehab protocol looks like. Now if you look at the results of this one, you can see that the success rate, which was 46.7%, 47% in the beginning, went up to 70.59%. And this is what is happening at home, and we are doing in a telemonitoring. You can see that the movement error is also, which was 0.46, reduced to 0.09. So there is a change which is occurring in the children in the initial stage, what we are monitoring them. Similar findings with the PDMS2 and Quest. You can see that pre was 50, which got up to 52 into the PDMS. The maximum score over here is 54 to 56 actually. So there is a good range of change which has occurred. Similarly, you can see the changes which has happened between protective. For example, in Quest also at all the levels of pre versus post. Though you can see that similar thing here, the child has already reached to the plateau over here, so not much changes, but you can see in the graphs that 94 has gone up to 96% of change. I mean, sorry, that's a 96.29% of changes. So, do you still think that rehab exercise for children with cerebral palsy is fun, or you think that still I'm kidding about it? I would say that rehab exercises for children with cerebral palsy is fun, and I'm not kidding about it. This particular work of computer game-based rehabilitation did not limit it to the only the SDM College of Physiotherapy. We conducted a lot of workshops, guest lectures, talks at various conferences. These are the glimpses what I am trying to show you, that we had almost nearly 50 participants which we conducted, one at the Kasturba Medical College, one we conducted at the national level, that is National Conference for Physical Therapists, and one was at the Potential Change for Children with Cerebral Palsy. One we conducted at Keshav Seva Sadhana School in Goa. We conducted the same into the National Physiotherapy Conclave, which was supported by the government, that is Ministry of Ayush. We conducted that on one of the National Conference of Common Health Association for Health and Disability in India 2019. We also gave a lot of talk into the postgraduate conferences and into the regional conferences and regional workshops and lectures at the different colleges, and we had got a couple of awards for the same when our students have presented on the similar topic. And we do have on a Facebook page which is promoting about what is all about the neurofunctioning gaming and how it is useful for physios and occupational therapists. Along with that, everyone has some contribution to be done towards the upliftment of the profession. As a physical therapist, I am. And in India, there is a struggle which is going on for the development of the council. So, I was one of the members in a parliamentary standing committee on health and family welfare Rajya Sabha Secretariat, where I presented the views on bill of the Physiotherapy Council bill. This is along with the Honorable Minister of Parliamentary Affairs, that is Sri Prahlad Joshi ji. And this is when we went to the Rajya Sabha, that is at the Standing Committee Rajya Sabha, Government of India, with Sri Ram Gopal Yadav ji, who heard our concerns about the Physiotherapy Council, and shortly we will have a Physiotherapy Council for the country. From here, I would like to move towards what future research I am looking for, or what future collaboration research we are looking for. We are looking for a treadmill instrumented with pressure mapping system, which is looking to be giving us all the details about the gait variabilities when we are doing a dual task, that is walking as well as playing in a computer game. And it gives the pressure mat is embedded into the treadmill, and then it gives them a good data about the gait variables and also about the MPL, that is mediolateral as well as anterior posterior center of pressure excursions. That's what we are looking for. We are looking for this one of the wonderful instrument which is called as Manipulendum. This is a modular computer controlled rehabilitation platform which operates to be assistive as well as resistive in finger, thumb extension, flexion and 3 wrist motions while performing broad range of goal directed object manipulation tasks. So we are looking towards this particular study along with Dr. Tony and his team, which gives a wide variety of objects to be used for manipulation. So this one would give us lots of variety to be using for the hand function to improve. That includes the thumb, fingers, lumbricals, thenar and hypothenar musculatures to be worked upon with the various degrees of wrist movements to be done. So here is a small video about the same.
Maybe try and hold it like with your fingers and manipulate.
So you can see here the manipulation with the fingers, you can see here the manipulation with the wrist which is going on, and it gives an assistive and resistive movements both.
Resistance on one side or assistance and assistance both.
Also, we are into the thinking that we have done a lot of studies onto the ground-based interventions, and we do have a hydrotherapy pool. So we would like to look into how technology is playing, because that's where the world is moving today. So I'm interested or keen to know what comparative studies if we do on land-based versus water and technology, and which one would show a better influence in outcome. That's what I am looking for in future. And definitely we are into the process of developing a multi-center randomized controlled trial in computer game rehabilitations, where we are going to involve 3 to 4 centers to collect the data and see how effective this tool is, what we have found it effectiveness into that. My another area of concern and research, as we are all aware that autism is in rise, so we wanted to develop some screening tool which is easy to administer, which should be also on a digital base, because we do have many on qualitative base, and also finding out the role of treatment strategies for developing the protocol, which will be having digital implications on that. Also, I wanted to look towards early intervention and role of technology. In early intervention, we talked a lot about the positioning, kangaroo care and all those. We have not been invented about what technology can play a role in early intervention with children. The biggest question, which is a social for me and for probably for the entire universe or world, is that one of the family came to me with the children with disability and asked me that, sir, I am there, I can take care of my child now. I can make him movable. But once the child is movable with some amount of deformities, and if I am not there, who is the one who will take care of this child? So that's probably the biggest social question which every country is facing, and how to take care of them. And I am really looking towards what best can be done for the children with neurodevelopmental disorder, which can be taken care for them for a lifetime and not only monitoring them for a period of time where they become ambulatory. Looking towards them as an adolescent, looking towards them as a geriatric population, how they would grow and how we can support them. So, with this, if you have any queries, you can post me on my email ID, or you can post to Dr. Tony on his email ID. We will be happy to share or to answer your queries, if any, on this particular topic. So with this, I would like to thank the University of Manitoba, Dr. Tony and his team, and my university, that is Sri Dharmasthala Manjunatheshwara University, whole administrative team, my postgraduate student team. And I would like to say that not to keep only a physical health, but we do need a brain health. And that brain health is nothing but a neuronal fitness. And while having a neuronal fitness, you should have a fun while doing that. And what I learned from this collaboration is that alone we can do so little, but together we can do so much. And definitely, if hands are close together, the child can rest with peace that yes, there is someone who is going to take care of me. So thank you very much for giving me this opportunity. Thanks a lot.